Logged on today to the Congressional Briefing Contact Tracing Teams, Voices from the Field. We estimate about 200 people are online with us right now, so thank you very much for joining us. I want to start out. My name is David Harvey. I'm the Executive Director of the National Coalition of STD Directors, and today's briefing is being brought to you by NCSD and the Alliance of the Association of State and Territorial Health Officers. So thank you, Michael Frazier, who is the CEO of ASTA, who is with us today for co-sponsoring today's events. In addition, we also want to thank the following members of Congress who are sponsors for today's briefing: Senator Gillibrand and Representatives Underwood, Crow, Panetta, and Jackson Lee. Today, we will be focusing on what contact tracing is. And so the presenters today will tell you a little bit about what contact tracing means from the front lines. And at the end of our briefing, we will also review various policy developments related to how Congress can support this function throughout the United States. Without further ado, though, I do want to introduce Congressman Jimmy Panetta, who is with us today. Congressman Panetta has proudly served California's 20th district in the U.S. House of Representatives since 2016. He currently serves on the House Committee on Ways and Means, the House Committee on Budget, and the House Committee on Agriculture. In Congress, he's been an advocate for agricultural history, veterans, and of course, most relevant to today's discussion, affordable and accessible healthcare and the response to COVID in the United States. So Congressman Panetta, welcome. Thank you for helping to sponsor this event today. And please take the floor for a few moments.
I appreciate that, David. Thank you very much. And thanks to all of you who have done so much work in this area in your participation today, and obviously to ASTHO and NCSD. Appreciate your work in this very, very important topic, especially when it comes to contact tracing. Funny, I was just listening, as maybe many of you were, to the hearing that's going on at the U.S. Senate with the members of the executive branch's task force. And it's funny, there's, repeatedly you hear mentioning about contact tracing, but unfortunately in a light with such comments as, well, because we didn't have a successful contact tracing program implemented, we lost that containment edge. It's having a successful contact tracing program is going to be a very key part of moving forward. It's the difference between succeeding or not, especially when it comes to containment of COVID-19. And so hearing these types of statements, obviously what most of you, many of you, if not all of you, knew, focusing on contact tracing, we do believe if we don't have a vaccine, it's how we get ahead of it. And as I looked at it is, basically if we all understand the itch to open it up, but as Dr. Fauci said, open up the economies. But as Dr. Fauci said today, we better be prepared to do that. And one of the ways I believe we are prepared to do that is only if we have a contact tracing program. Those are one of the tools that we can use to do that. Now, what tools do we have? We don't have the best tool, and that's a vaccine. So we've been implementing a blunt force tool of shelter in place. What we'd like to do, what you'd like to do through your work is make sure we have those sharp incision type tools of testing and contact tracing. And as I look at it, I think we have these Swiss Army knives. Basically, we have an existing infrastructure of contact tracing forces within each county, within some states that have implemented these types of tools before. And what the Health Force and Resilience Force Act does, the bill that Senators Gillibrand and Bennett and myself and Jason Crow and Lauren Underwood are putting forward, have introduced, basically is that it provides money for numerous Swiss Army knives when it comes to contact tracing. $55 billion per year for the next 2 years for people who will test, contact, isolate, care, and message and inform. Basically all of these parts of that Swiss Army knife that they'll be able to use. And it's sort of taking advantage of the existing infrastructure that's already in place, sort of a bottom-up effort. Now, there are other efforts in Congress, as I'm sure you know, to develop a national force to do this. That's more of a top-down, which I appreciate, and we're going to get there, and I actually support some of those bills. But I think now we need to deploy this Swiss Army knife sooner rather than later. And I believe the best way to do that is make sure that we have the funds there through our bill to then reinforce the existing infrastructure that's there in the states, in the counties, in these cities, of that infrastructure that's been there, that's worked when it comes to contact tracing, and then develop with the resilience force, develop that force through FEMA to make sure that there's people there who are trained not only to be contact tracers, but to also be deployed for natural disasters as well. And I believe that this is the way to go, especially considering the position we're in, especially after what we've heard today through that Senate hearing. Contact tracing is the way we get through this. Contact tracing is the way we see this. We block, we cut off that chain and we contain it. And I think it's been proven before. And that's why we put forward this bill with the sage wisdom of our wonderful two amazing freshmen, Lauren Underwood and Jason Crow, to author this bill and put it forward. And we know, as well as you know, that we couldn't do it without your help. So once again, wanted to say thank you. Look forward to continuing to work with you as we go forward with our legislative efforts and hopefully deploying our Swiss Army knives of contact tracers throughout this country. So thank you again, David.
Congressman Panetta, thank you so much for joining us today. And that was a wonderful primer into some of the issues we are about to be discussing a little bit more in depth. And before I do that, I want to go over just a couple of logistical items. First of all, we are on a Zoom platform. There are a large number of people on this platform. We want to make sure we're disciplined with the presentations we're about to move into. So each of our presenters will be doing about a 7-minute presentation. And then we want to make sure that we have very significant time at the end of this time with you to allow for questions and answers. I think by now, all of us have become very familiar with Zoom, but just as a quick reminder, you can raise your hand. Taryn Kuchar, who is a colleague from NCSD, is going to help to manage this process of taking questions both through the raise hand function as well as the chat function. So you can write your questions in the chat function or raise your hand. Taryn Kuchar and Matt Pryor from our NCSD team will help manage that. The order of our presenters today will be as follows. Guadalupe Valdivinos is with the Houston Health Department and is a STD contact tracer, disease intervention specialist. Following Guadalupe, we will have Danucha Brick-Shavana, who is with the Illinois Department of Public Health and chief of the STD section, talking about the Illinois response to COVID and contact tracing. With Danucha is Toby Valicia Johnson with the Cook County Department of Public Health STI/HIV program. Following Toby will be Amanda Dennison, the Deputy Executive Director for Programs at NCSD, talking about training that both ASTO and NCSD has just launched a week ago online nationally for entry-level contact tracers. And then last but not least is Dr. Michael Frazier, who's the CEO of ASTO, who will round out our discussion today with an overview of policy issues and a coalition ask of the national public health community. Before I ask Guadalupe to speak, I wanted to review just a couple of basic overview of the issues we'll be reviewing today. I think, as we all know, in terms of the discussions around contact tracing, this is something that we have done in the United States for decades. This is a core public health function of health departments. We have the expertise within health departments to know how to do this. We have to allocate the resources, both training and the additional resources that we need to hire additional people, and vest those within health departments to ramp up this function, which we know is key to reopening the American economy. Typically, you will hear the concepts of testing, tracing, isolating, monitoring. These are the key concepts of contact tracing, but today's briefing will really humanize this approach so that you can see, those of you who are in Congress and making very important decisions about how to shape policy and allocate resources, you will see how these principles are put into place by a culturally competent workforce that knows how to reach those most at risk for COVID. And we know what's going on right now is that disproportionately African Americans and Latinos are impacted by COVID. It is extremely important that this workforce know how to work with these communities, come from these communities, and we have the expertise within health departments to know how to do that. So one more introductory kind of framework for everybody to know about. The national public health community has rallied around an approach that basically has a three-tiered approach to supporting this work with a lot of variation within health departments. We need entry-level contact tracers. We need disease intervention specialists who can supervise the entry-level contact tracers. And then we need the medical epidemiologists. Most of the proposals that have been advanced to Congress focus in on the three-tiered approach and how to best build the system within that framework. Without further ado, I want to welcome Guadalupe to today's briefing. Guadalupe, 7 minutes. Take it away.
Yes, hi, good afternoon. Thank you for having me here today and allowing me to shine a light on the work of contact tracers. So often I'm asked, where do you work and what do you do? And when I bring up disease intervention specialists, they look at me like, what is that? Right? So that brings me to the question of what is contact tracing? Contact tracing is a disease control measure. It's a public health effort to stop the transmission of communicable disease. This is not a new initiative, not a new strategy. Contact tracers have been tracking infections for decades. I've personally been doing it for the past 5 years. But before I proceed, I want to briefly share where we stand as far as case numbers and contact tracing efforts. So currently here in the state of Texas, we have over 35,000 confirmed cases. Houston-Harris County has about 8,000 confirmed cases. And at this time, the health department has about 125 individuals who have been deployed until further notice from other areas of the department to fill in the role of contact tracers. Most staff being pulled from the STD HIV Bureau. We have 19 STD contact tracers and 8 have transitioned to COVID-19 contact tracing, including myself. So we have programs working with a limited staff as they continue their operations. So now to the question of how do we do this job? So in the world of STDs before COVID-19, it looks different. So we locate those who have tested positive for a sexually transmitted infection such as syphilis and/or HIV. We ensure that they receive adequate treatment. Sometimes this means that we're having to transport them in our own vehicles or giving them bus passes. And then we have this face-to-face conversation where very sensitive information is shared, such as their sexual history, drug use, sexual orientation, sex partners, which is very important. Very, very personal information, and STD contact tracers obtain this information from people daily. That's what we do. So once those sexual partners are disclosed, we notify them of the exposure and we ensure that they are tested and treated. And during this entire process, we maintain patient confidentiality. And in response to COVID-19, the process is very similar. However, due to our county's stay home, work safe order and social distancing guidelines, all field services were suspended. So like I said, my day-to-day work looks a little different. All efforts are done by phone, and obviously I'm dealing with a different infection. So what I do is I call the person confirmed of having the virus. I discuss a plan with them to self-isolate so that they do not spread it. I then explore symptoms with them. So I help them recall the onset of their symptoms, the duration of symptoms, and who and when they've had contact with during the time that they were ill. So dates are very important for us because that helps us determine when the case is released from isolation and when the contact's 14-day quarantine period begins and ends. So I always have a calendar with me during the call. For example, I let them know, so you were tested on the 5th, which was a Monday. When did you begin feeling the symptoms? When did you begin feeling sick? You know, they're like, And so it's like, okay, well, let's talk about that Saturday prior to that Monday, right? How are you feeling that morning? What did you do that day? And so that kind of triggers back and allows them to remember that information that's very important for us to use. So once that's done, I then call all contacts to notify them of the potential exposure without disclosing the identity of the source. And that's very, very important. And then I'm also checking in with the contacts daily until they're released from their quarantine. So during this time, I'm monitoring their temperature. Well, they're doing it, and then they're letting me know, okay, no, I didn't have one. They do it twice a day. And then we're watching out for symptoms. And should they become ill, I refer them for testing. And this is what allows us to break the chain of infection. Without intervention, the person infected with COVID-19 comes into contact with others and potentially exposes them, right? So these individuals then interact with other people, expose them, and it just becomes a cycle. So the goal is to quickly isolate the source and quarantine those that have been exposed so that they're not passing the virus along to someone else. And then that's how transmission is interrupted right there. And so I'll share just a quick story that I recently had. We had an individual, a father who took their daughter in for testing, and they hadn't been notified. The provider didn't notify them about the positive test results. And so by the time we got to them, they had already been out. They had visited grandma and grandpa. And so dad was like, had I known this earlier, we would have never made that visit to my parents' home, right? Because now we have a grandma and a grandpa that have been exposed because that person, the source was not isolated. And so I say this to just let you know, guys, that time is key. So the quicker that the patient is isolated and their contacts are placed in quarantine, we have a better outcome. We can't get to them as fast, but we can't get to them as fast without more contact tracers, right? So due to the magnitude of cases and not enough bodies right now, that's when we begin to see a backlog. And instead of working the newly diagnosed cases, we're finding ourselves working older cases. And at this point, we're not effectively intervening in the spread. Not to mention, we're still maintaining our work in STD HIV. We can't afford a gap in services in the area. So the deployment of STD contact tracers has placed a toll on regular STD HIV operations as they continue to operate with limited staff. And so we don't know how much longer this COVID-19 outbreak will last. And the last thing that we want is to look back and be faced with another outbreak of syphilis and an increased number of HIV cases. We can't contain one and lose control of the other. I know this might sound extreme, but I mean, it can easily be a reality. And that's exactly why we need to expand this workforce. In this phase, we need approximately 300 additional skilled contact tracers to meet the increasing demand. And contact tracing is a specialized skills, right? This work requires special analytical skills for it to be done effectively. And I know I couldn't have done it without the expertise that I've developed over the years in the field, learning how to build quick rapport with patients and gaining their trust. So I'm just confident that with proper training, funding, and resources, contact tracers provide an essential service, and tracing is key to prevent further spread.
Guadalupe, thank you very much. I'm now going to call upon Danny Brick-Shavana from Illinois. Thank you.
Perfect. Thank you, Guadalupe. I'll be able to provide some overview of the statewide perspective, and I also have with me a local STD HIV program manager from Cook County Department of Public Health, which is the second highest morbidity in the state outside of the city of Chicago. Chicago gets about 50% of all of our morbidity, and it is, again, distinct from the Chicago Department of Public Health. I do want to say that STD programs across state and city jurisdictions may differ from program organization to resources available. However, what maintains continuity is the importance of contact tracing, counseling and partner services, disease intervention specialists that aid towards prevention. So the overview of the current status of COVID in our state. In Illinois, there's about 80,000 positive COVID cases right now and about 3,500 deaths. Positive COVID cases are almost exceeding the positive chlamydia cases, which is the most nationally notifiable infection in the US in all of Illinois in a matter of 2 months. So as soon as probably higher, all chlamydia, gonorrhea, and syphilis combined, I can probably see COVID positives going above and beyond that. And our state, like many, is decentralized, meaning the autonomy is at the local health departments, and the districts who are have the responsibilities to do STD prevention, surveillance, and case monitoring, as well as clinical services. IDPH STD section functions primarily through federal funds and support from the Division of Labs for STD testing. And there is no state or regional disease intervention specialist. So Illinois does not have dedicated state funds to support STD efforts in the state, and therefore we do not provide extensive resources to locals to conduct STD prevention. DIS work is all reliant at the local level to support their own programs, personnel, and resources. So Illinois, there are about 300 DIS in total in the whole state. And just to show you that how much the STD program infrastructure has changed in time, in the city of Chicago in the late 90s, they had about 120 DIS employed. That's including field and supervisors. And now there's only 13 in the entire city of Chicago. And during the time when there's also, with this alarming rise of STDs and now with COVID pandemic, we can see that the infrastructure has diminished. Whereas also Cook County, which I'll be introducing Toby, will speak today, they had 15 STD HIV DIS, and now they currently have 5. So I'll turn it over to Toby Lucio Johnson, the STI HIV Program Manager at Cook County. She has 20 years of experience in the field of STI and HIV.
Hi, everyone. Like Danny said, we basically have very limited staff right now. Everyone has been pulled to do the COVID work. And Guadalupe actually summed up everything very well. A lot of the same talking points that she made, I have those same points. So our entire unit, field staff, surveillance staff, my DIS supervisor, and myself, I'm the program manager over both the STI unit and the HIV unit. We are all doing COVID work. My staff, they all do the case investigations, interviews, follow up with providers. They link the cases from long-term care facilities, nursing homes. Again, there's not enough staff to do all this work. They are trying to do a little bit of their regular work as far as STD and HIV, but I would say 90% of their work now is focused on COVID. As of yesterday, May 11th, we had over 20,000 cases for suburban Cook County. And remember, Cook County is separate from City of Chicago. And as of yesterday, we've had over 800 deaths. And as far as being responsible for overseeing the DIS, that would be myself combined with the DIS supervisor. Normally when they work in STD and HIV, it's very similar to what Guadalupe was saying. The cases for my agency go to surveillance, then those cases are assigned to the DIS supervisor, and those are assigned to the field, and the DIS investigates the case. However, right now with COVID, they cannot go out in the field. They have to talk about these cases over the phone. And with our DIS, they are specifically trained in STI and HIV disease case management. They are able to work with patients to reduce their risk. They have the ability to work with patients. Again, as Guadalupe already said, they create a rapport and trust with patients so that they can talk about difficult subjects.
Yeah, great. And I also wanted to include that, at least to show the importance of counseling partner services in the state of Illinois, it's required by law for all local health department staff who conduct extensive STI and HIV counseling partner services, and to actually take an IDPH approved or CDC approved training, because this is how important that you have to be able to understand and be able to talk to the individuals in such a short period of time, you're a total stranger and you have to talk about their private information. And so what does that mean? What supports does the state and like the county need to respond for COVID? And I think in general, it's always going to be the resources, whether it's funding, personnel and training, whether it's at the state level or even the local level. And if anything, the locals, especially if it's a state like us who's decentralized, the locals really are suffering and they need that extra support to be able to do and conduct the work that they barely have enough resources. So Toby, can you talk about the supervision of any scale of contact tracing as necessary?
For the purpose of COVID, the supervision that they really need right now is emotional support, because as I've already stated, they are very well trained in what they do as far as working with cases, working directly with patients and with clients. They're listening to heartbreaking stories about the impact of COVID on the family. While the staff is very compassionate, they have to be compassionate and professional. However, we need to remember they're talking to real people. So the staff, they are very emotional about this. Again, they are specifically trained for case investigation. They encourage the clients to speak. It's difficult to talk to a random person over the phone. DIS are accustomed to working in the field where you can determine how you have to approach the clients. But clearly, they're doing very well with this under the circumstances because, again, when they're talking to these patients, they have to get through certain barriers while getting the patient to trust them. And then again, they need the emotional support of myself, I'm the program manager, and of their direct supervisor, because it's an emotional thing that they're doing as far as working with COVID.
Yeah, because especially as a public health, we know that sometimes, and we work with paper, but we also ultimately got to remind everybody that we, in the end, work with people.
Yes.
So, thank you.
Thank you both, Danny and Toby, for that excellent back and forth and overview. And I just wanted to make sure that what resonates with our audience today is that all of the presenters you're hearing today are doing work already within epidemics that are out of control. STDs, HIV, there's a history as well of contact tracing with Ebola, Zika, but currently in the STD, HIV arena, we have, particularly in STIs, the highest STI rates probably in American history. So we're, as a field of contact tracers and disease intervention specialists, these are a set of skills that are employed for any infectious disease outbreak. And folks who do this work every day are no strangers to out of control epidemics. I want to move right on now to Amanda Dennison from NCSD. Amanda.
Thank you all. I'm going to cover a little bit about the joint training that ASTO and NCSD developed last month. It is called Making Contact, a training for contact tracers. This training began to take shape in late March as both organizations realized that there was a growing need for a basic entry-level training for new contact tracers. We estimate that the US needs an additional 100,000 contact tracers to adequately support the COVID-19 response. And as states and locals are identifying ways to rapidly hire for these positions, we knew that the training would need to be immediately available for the new hires. So NCSD and ASTO developed this training very intentionally to provide the foundational knowledge for contact tracing. As we moved through the development process, we consulted with national experts, especially in terms of content development and review. Those partners included CDC, the Council of State and Territorial Epidemiologists, the National Association of County and City Health Officials, state health departments, the NCSD Disease Intervention Specialist Committee, and other national partners. The foundational training is currently hosted on ASTO's learning management system, and we've also partnered with CDC to make the training available on their CDC Train system. The training takes approximately 3 hours to complete and is completely free to all users. I'm going to walk through just a little bit about what that training entails, what the content is. There are currently 4 lessons included in this training. We start off with a basic overview of coronavirus disease 2019. We start with a foundational knowledge of what infectious disease is, key definitions, key terms that will be used by contact tracers and their colleagues at health departments. What the role is of public health in terms of addressing infectious diseases within communities. And then we get into COVID-19 specific information, including terminology, prevention, what is community transmission, what happens when the virus enters your body, and so on. So we really do give kind of an in-depth overview of what COVID is, right down to symptoms and testing and incubation and infectious periods, etc. From there, we move on to the basics of contact tracing. We really get into kind of what are the goals of contact tracing, and again, the key definitions that are needed for a contact tracer in this role. We talk about the fundamentals, the 4 steps that we have identified as part of contact tracing, the difference between contact tracing interviews with perhaps that original case and their contacts, calculating timeframes, and so on. From there, it lends itself very easily to transition over to effective communication and interviews. We really spend a lot of time talking about effective communication techniques in this period. As Toby mentioned, it can be difficult to assess situations and have a conversation over the phone with people that you haven't met. All you have is some information in front of you. So we talk through motivational interviewing, risk communication, and we also give a very in-depth overview of culture and cultural humility and sensitivity, making sure to include information regarding stigma and discrimination and what potential impact that could have on your interviews with the community. The last lesson is an overview of case monitoring and resources. We talk a little bit about crisis counseling in this section in terms of identifying immediate needs to enable the cases and contacts to participate in whether that's self-isolation, quarantine, what are basic resources that they might need, but also what are some social supports that they might need. Both Guadalupe and Toby talked a little bit about the transportation issue, what childcare they might need, things like groceries and other social supports. Each lesson that is included in our training requires that the participant or user pass a quiz, and at the end, when all quizzes have been passed with 100%, they receive a certificate. We have discovered that this certificate is very much an incentive for users as well as states. Currently, as of yesterday, we have had just about 15,000 registrants, and this is since April 28th. So we are seeing an average of over 1,000 unique registrants every single day since this launched, and we have about 7,500 individuals who have completed the training and received their certificates. We expect these numbers to increase dramatically as we've talked to other states that are now requiring our training as the first step in their training academy going forward. States such as California and Indiana and others that are using our training to provide that foundational knowledge. So we'll be seeing that number increase pretty drastically over the upcoming weeks. We will continue to provide updates to the training as needed, specifically around testing and treatment, making sure that the content that we provide is up to date for participants. And we also plan to expand beyond the original 4 modules or lessons to include more in-depth information, and that will be a little more specialized beyond that foundational knowledge piece. So I think that's it for the overview of the training that we provide. So I'm going to turn it over to Michael now for next steps.
Yeah, Amanda, before you do, thank you so much for that overview. I just want to say how thrilled we've been to join with ASTO and doing this initial training and wrapping this up. And I also want to say, which picks up on the theme of what you talked about in terms of designing this training for contact tracers, working within health departments. This has been a theme throughout each of the presentations today. Contact tracing is a unique core public health function vested within health departments due to very specific legal and policy considerations for how information is protected. And so without further ado, we are thrilled that you have joined us, Mike. So take it away. Thank you.
It's been a great partnership. I got to tell you, I've been talking about contact tracing now for some time, and it's really refreshing to actually hear some contact tracers talk about contact tracing. So thank you guys so much for the work you do in the states and local areas. I'm always awed by the work of public health, and I really appreciate you and your leadership as well. My role here is really just to emphasize some of the messages that our experts shared, and what a great group. You know, the demand for contact tracing is high. There's lots of estimates. There's lots of numbers out there. You know, we really set a floor in terms of our estimate of what's needed for the next phase of viral suppression and eventually recovery and restoration. In a document that was co-sponsored by both the NCSD and ourselves at ASTO, but also the Association of Public Health Labs, CSTE, the Council of State and Territorial Epidemiologists, and NACCHO, county and city health officials. I think it's important to remember that not every state has a decentralized state-local system. There's a number of states in the nation that are both state and local health departments. Think about a state like Rhode Island, you know, in terms of geographic size, but also a state like Alaska, where there's just one municipal health department, and the state health department does a lot of the outreach around disease investigations. So there's a real mix of how states and locals work together, and who's on first when it comes to the frontline contact tracing that we heard so much about, particularly around STDs, STIs, as well as tuberculosis and other communicable disease investigations that need to get done. I would also just again echo the fact that what we are seeing with regards to the need for DIS, disease intervention specialists, as well as contact tracing more broadly. This is not a topic that popped up with COVID. We've seen decreases in the workforce over the last at least 10 years. As David mentioned, we've seen a commensurate increase in the rates of STDs. The burden of disease is high, and the number of DIS in state health departments to support the really tough work of contact tracing just does not meet demand. So states have to prioritize. And what we see in an emergency is the emergency gets prioritized. So as Guadalupe and others mentioned, the whole fact that, you know, who's doing the HIV, STI investigations in the middle of this global pandemic? It's the same people doing the work of COVID. It's not a sustainable system, and we need a lot more support. Our organization's estimated that about 7.6 billion is needed to rapidly expand to at least 100,000 contact tracers, at least 10,000 new disease intervention specialists who would serve as supervisors for those contact tracers, and at least another 1,600 epidemiologists. When you put together the staffing needs, the technology needs, and some of the other pieces in our proposal, we have basically a floor ask of about 7.6 billion. That for us is really this first pass. This is what it's going to take to get COVID under control. I hope we're also thinking about the long game here, which is building back the state and territorial local public health infrastructure, which is so vital. we are going to get through this outbreak. We are going to see public health rise to the challenge. It's just a matter of how long it's going to take and how quickly we do it. And as was mentioned, every day that we wait to bring these folks on board is a day that we're seeing exponential infection, and certainly won't be able to control COVID in any significant fashion with the number of staff we have today. So that's why states are ramping up quickly. I can tell you the dollars that have gone to states to date specifically for the work of contact tracing, they're difficult to track. What we know is there was a first emergency supplemental that was passed and signed by the president, which provided about $1 billion to state, local health departments. The first pass at that was put out in record speed by CDC, and states have about 631 million of that they're using now. We think some of them are using that for contact tracing. We also know that in stimulus 3.5, we have 25 billion for testing. And in the legislative language there, and the direction that was given to HHS was to use that for testing, but there are pieces in the legislative text that refer to contact tracing. So it's unclear which piece of that, and practically impossible to tease out which piece of that is going to be used for testing equipment, supplies, what's going to be used for tests for laboratory staff and workforce, and what's going to be used for contact tracing or disease intervention specialists workforce expansion. So for any of the proposals that have been put before Congress to consider and introduced, we have a set of principles that I summarized in a link that I posted in the chat if you're interested in looking at those. But what we'd really like to reiterate is this expansion of the contact tracing workforce really needs to be rooted and connected to the state, local, territorial public health infrastructure. Creating program outside of that will be confusing. It won't be connected. And again, it goes around the fact that states are doing this every day and have been doing it for years. So we're hoping that as the workforce has expanded, that there's a strong coordination mechanism between states and local health departments. We also really feel like volunteer sort of management systems should not be set up apart from the existing emergency response in a state. So as we onboard new contact tracers, and obviously we want them to be professional positions, but also manage potentially surge volunteers, that's all integrated within the current public health system, our FEMA emergency management system, as well as the CDC, federal, state, local health department emergency management. We also feel like there needs to be flexibility here, as mentioned. Some states are low population, high geography, and they're going to need more resources to be able to connect to remote communities. So some states are high population and small geography. They're going to need a lot more kind of contact tracers to scale up quickly to large metropolitan areas. Finally, again, I would just say that the response recovery is primarily based on three things. It's based on our ability to test. It's based on our ability to have folks, the public comply with isolation and quarantine. And it's really, really, as David said, based on contact tracing. It's not a magic bullet, but it's the one tool we know works in public health. It's tried and true. And at this point, we don't need a lot of new, we need a lot of new workforce. So with that, David, I'll turn it back over to you.
Thank you so much. Appreciate that overview. We are now going to move right into some questions, discussions, answers with all of our panelists today, which includes you, Congressman Panetta. There may be some questions related to your legislation and thoughts about how to move forward in the Congress. So thank you for sticking with us today. And I'm going to turn it over to Taryn Kuchar and Matt Pryor, who are going to facilitate and direct the questions to members of the panel today. Thank you.
Thank you. And just as a reminder to everybody, please type any questions that you have in the question and answer pod at the bottom of your screen, or raise your hand and I will unmute you. So we do have one question that I'm going to raise to Guadalupe or Danny. Please, either one of you feel free to answer this question. How do asymptomatic individuals factor into contact tracing plans?
Oh, Guadalupe, you might be on mute, but for asymptomatics, I think with identifying and I guess on how each state or each jurisdiction is going to be able to hit the thresholds and to be able to really parse out the task. So I think for asymptomatic, it's the questions that you got to be able to ask and do the epi work and decision making to find out.
And Danny and Guadalupe, if you could also comment on the issue of presumptive positives and how even though testing may be limited, you're still doing contact tracing who potentially with people who have been exposed and making recommendations. So just wanted to throw that into the mix.
Yeah, so testing is helpful to confirm the infection, but it's not necessarily a precondition, right? So this work can be done even with the absence of the test, because we still initiate the public health follow-up process with a presumptive diagnosis. I mean, it's better to be safe than sorry, right? And so yes, testing helps, but we can still take the public health measures without that laboratory test.
Correct. And there could be also situations about timing when they might have been tested versus when they were contacted. And so sometimes in the investigative work to be able to identify, you might be able to figure out some more stuff versus just being the laboratory alone.
Gotcha. Toby, anything you want to add?
No, they answered perfectly well. Thank you.
Okay, very good. Taryn.
I'm going to throw this to Amanda, and then please, Toby, Danny, or Guadalupe, also feel free to chime in. We have a question of how can we ensure that new contact tracers are culturally competent and trusted by the community?
That's a great question. Our training goes in depth about some methods to do that in terms of not perpetuating any stigma and discrimination, understanding some cultural traditions or other beliefs that may, impact their ability to self-quarantine or self-isolate, how they interact with doctors and other medical field in general. So understanding their community and understanding their community needs, I think that's one thing that's really special about DIS in particular, is that they often come from their communities. And so they have a deep understanding of the different cultures that exist within their communities, how to interact with them, and what their needs are and where those resources exist. But I will certainly turn this over to our partners for some more information.
I'd like to add something to that. In addition to being culturally competent and being well trained, I think that sometimes we as public health workers have to realize that sometimes we have bias. And a lot of times it's unintentional, but we have to know that it's there and we have to understand it. And a few years ago, working with the state of Illinois, I did a cultural competency training for a few years on how to work with the Black and Latino MSM and transgender population. But again, the point I'm trying to make is that in addition to understanding your population, you have to understand yourself, and you have to understand that whatever you have in your mind about that person in front of you, you have to look at them as a human being first. You have to understand that they might have some barriers that happened to them prior to coming to you. So that's it.
And I think on the kind of the management side, how do you learn about that? I think a lot of that is experience. And I think the hardest part is actually first asking yourself, but also making sure that this is why there's the tier effect, where maybe the DIS who do have training, who have been doing the interviews and culture competent to be able to learn from these as supervisors for contact tracers.
Great, thank you. We have a question here I'm going to throw to Mike and David. Understanding the three-tier system, epidemiologists, DIS, and contact tracers, would federal DIS be deployed to states, or would there be a mix of federal, state, and local DIS who would supervise the contact tracing efforts?
Yeah, I mean, I think, again, it's going to be really different in every state. I would assume in a very decentralized state, a lot of that would happen locally with local supervision, folks adding to the DIS workforce in either the big cities or large counties. In the more centralized states, obviously, I think it would be more at the state level where there's either district offices of the state or a state central office where a lot of the kind of management and administration is, and maybe even where some of the call centers are. So I think it's going to be varied. It's going to depend on the state, but the place where I think we need states overall is to help with the statewide plan and really make sure that we're coordinating locally so that not only that we have enough, but also maybe we're not duplicating. And that's something that does happen sometimes when you go direct state and direct local without coordination. But I don't know, David, what you think on that.
I guess what I would add to that, I completely agree, Mike, but I would also speak to the federal coordinating role. I mean, we all know here CDC has incredible scientific expertise, and tapping into that knowledge and experience is very important. It's what we need at the national level now. Having additional resources, additional standards, guidance, help provided to the states at the federal level, from my perspective, is extremely important. Knowing that each of the states and local jurisdictions are going to structure this in different ways. But there is a very important role for CDC and the federal level of government to play here in issuing national standards and a plan. And I think we're waiting to see that come from CDC. CDC has developed some wonderful resource materials, but I think that working together, we can do even better in that regard. So we're looking forward for next steps there. I will also say that one additional point, all of us in one way, shape, or form today have spoken to the issue of not reinventing the wheel and using the existing expertise of health departments. And we know how to do this work. We have done it for decades. Disease intervention specialists and contact tracers go way back in American history, and it is vested in a number of infectious disease and communicable disease work. HIV, STDs, TB is a very important historical marker here as well for the role that contact tracers have played in confronting infectious disease outbreaks. And at the heart of foodborne illness outbreaks, Zika, I mean, you name it, you will find this function within health departments. So more leadership and resources and money from the federal level, provided from Congress to CDC, and then the states and local jurisdictions taking those resources, using those national standards, and implementing them in a way that works for them.
Great. Next question, I'm going to start with Mike at the national level and then ask maybe Danny at the state level. What sort of technological resources are you looking at, and what is the role of technology in assisting with contact tracing capacity?
Sure. So there's a lot of talk about technology and apps specifically around contact tracing, and there's some great stories of and coverage of the apps that are used overseas for contact tracing. One of the things I would say is there's really two different kinds of apps. There's apps that a health department uses to connect with individuals who may be in isolation or quarantine, which basically allows them to communicate via either the text or the app itself rather than the telephone or in person. And so especially if you're just doing, temperature check, or you're doing a how you feeling today kind of check, there's apps that can do that. There's an app called Sarah Alert that was developed by a group of us in public health to do just that. And it helps just do the home monitoring and connecting with the health department, again, to make things easier. The place where we see the most interest are these apps that do the alerting, whether it's a Bluetooth or some GPS. And look, to be honest, I have not seen one that will replace the interaction that a contact tracer or a DIS has with an individual patient. A lot of these apps are not precise enough to lead to public health benefit, and you're going to get a number of folks alerted because they were within the vicinity, but maybe not within the 6 feet, and maybe not within the 15 to 30 minutes, and maybe not in the last 2 days. So I would say it's a great and interesting technology, and certainly it can help folks potentially recall where they were if they need to be contacted by the health department and be able to say, oh, okay, yeah, in the last 48 hours, I was at the grocery store, I stopped by the gas station, and I went back home. But in terms of an automatic alerting, I think many of us have concerns about the public health utility of that with the kind of technology that's there now. And also, that's sort of taken some air out of the room where we really need to be talking about the people we need to do this, not the technology. Technology is going to be supportive, but not replace people. And somebody's got to connect those apps to a laboratory system. Somebody's got to make sure that individual confidentiality and privacy are compromised in those apps. And so, we've been contacted by numerous vendors, all of whom have a really interesting product, but we just want to make sure that we're coming at this with a public health perspective, not sort of the new gadget or whiz-bang program. And that the apps that are going to have the most utility are going to be apps that complement what DIS do today, potentially making it easier for patients to communicate, or folks that want to text versus use the telephone to reach back to the health department and vice versa.
I just want to add, that was a great overview, Mike. And I just want to add, Google and Apple are getting a lot of attention. I think we all welcome innovation and tech companies helping out, but nothing replaces the workforce that's needed that does this work person to person. And I also just say that in addition to Sarah Alerts, there are companies that have worked in this space for a long time, smaller companies that aren't necessarily as well known, and they have a lot of capacity to supporting this work if the money is there to kind of support this. And one example, in addition to Sarah Alerts and MITRE, is a small company in Virginia called Checks Out that has a great platform. But local jurisdictions will choose and should choose a platform that works for them. But having information and standards and guidelines that goes along and help states to make those informed decisions about what platforms work the best for them is also another example of national federal leadership we need.
And if I can just add a little bit to that, I think that these apps don't take into consideration everyone that's being affected by the COVID-19. For example, our senior population, where some of them might not be that tech savvy. So you're leaving them out of the equation when you are trying to just implement these apps. And it, like Michael said earlier, it does not replace that person-to-person connection that's needed to build that rapport and to establish that trust with the individual.
The very population most at risk for COVID,
right,
is probably going to be the least, a group that's going to use that technology. I think Guadalupe could not have said it better.
And David, if I may, I completely agree with Guadalupe. Obviously, you're the boots on the ground. You know what you're doing. But the trust aspect is also important to get over the privacy issues as well. And so I'm sorry that I have to leave. I have to remove myself from this Zoom or however you call it nowadays at 11 o'clock. But I wanted to ask, if I may get in a question there about
Sure.
privacy concerns, and talking to those of you who are on the front lines. What are some of the issues that you are hearing when it comes to privacy, if at all? And does trust actually overcome that, as it does with most patient-doctor relationships?
I was going to say, Toby, your team encounters a lot, probably also Guadalupe. But confidentiality is very, very important, and then to the point where we have extensive more training on data security and confidentiality. And one of those things that we have to address also when talking with other individuals is about the protection of the information, and how, sometimes we can assure individuals by explaining how we protect it. And should people ask questions, this is how we respond, so that they can be assured, so that they can answer honestly and truthfully. But sometimes it really depends on the person's rapport that you create with an individual.
yeah,
I agree with Danny, but I have found that, I have found that worst comes to worst, back when I was a field epi years ago, if I told a client, if I give out your information that I am not supposed to pass to anyone, quite honestly, I could be fired, and I do need my job. With some people, I have to say it worked with them. And one thing that we all experience as far as doing direct service work, you have to know what your approach should be for that client, and you have to know what would work. And that worked with some people.
Yeah. And, you know, they want to make sure that their information is confidential. And so we just have to reassure them that, hey, your information by law is confidential, you know, and one of the questions is, well, how do you notify my contacts without telling them that I'm the one that exposed them, right? And so I will actually sit with them and go through the process of, okay, let's pretend that you're that person. This is how that conversation looks. So that they're like, and then they're like, oh, okay. Like they didn't realize that it was possible. And it is possible to actually let someone know, hey, you've been exposed to COVID or a sexually transmitted infection without disclosing the source information of the individual who actually is positive and exposed. And after that, they're like, okay, so I've been in contact with A, B, C, and D. So yeah, that is very, very important.
I'm happy to see
also,
that
if
I'm
I
not
could-
the only person that was doing role plays, because sometimes role plays is how they understand. So I'm very gratified that you brought that up.
There could also be a strategy in regarding to not telling the person, meaning the staff employee who the index case or the original patient is. Here's the contact, that's it. So the person, when they talk with the client, they have no idea who the other person is. They can't disclose that information. So there's also strategies.
Once again, thanks to all of you for all of your work, UCSD, AASHTO, and all of you. I look forward to continuing to work with you. But once again, like I said, I think it's important that people hear from you, those of you who have actually been on the ground, been on that phone, talking to these people and facing them. And I really appreciate your work and look forward to continuing to highlight your work and bolster and strengthen your work as we continue to fight this pandemic and eventually get ahead of it. So thank you very much. Thank you, David.
Thank you.
Thank you, Congressman.
Bye-bye.
All right, we're going to move on to one of the next questions. And I'm going to, I guess, start with Amanda on this one. Do you suggest that new contact tracers have the opportunity to role play and receive feedback via Zoom prior to reaching out to cases and contacts, and is that possible?
Yes, I would say absolutely. It's important to prepare for your interview. So in our training, we walk through every single step of an interview. We provide sample scripts. There are some interactive pieces where you can kind of walk through, if you encounter a confidentiality question, how do you handle it? If you encounter someone who is angry that you are contacting them, how do you handle that? But at the local level, yes, they should be really kind of walking through what that script is and practicing, you know, with their supervisors. If you have a DIS supervisor, you have someone who has done this work for a fairly long time. They have done these interviews, and they can walk you through kind of you know, points about motivational interviewing, what your interview or communication techniques can be. So I do think it's important to have that experience, you know, kind of role playing that, and especially different scenarios that you might encounter. I think Guadalupe and Toby covered some of what those scenarios look like, and how you, you know, provide basic resources over the phone or social services over the phone. So talking through those and, you know, practicing with your supervisors. And it's something that NCSD and AASHTO have included in kind of their supplemental training suggestions for local and state health departments. But I don't know if the others have anything to add to that in terms of role playing and training.
I guess the only thing I would say is our course is online and it's meant to be awareness level, and to really complement the Zoom role playing and the practicing that needs to happen. I don't think you can just watch a video or read a set of slides and get some of the nuances and practice that you need. And that's why we're talking about working with professionals who have done this work and using working with those folks to train new contact tracers that are part of a system. And so, yes, you need to role play, you need to practice, and you need to have face-to-face communication whenever possible as you learn this really important skill set.
Great. And David, I'll start this question with you. What do you see as what would be the future use for these DIS or contact tracers once we are able to get a handle on COVID-19?
Very good question. So first, we know the public health system has been completely underfunded for decades. We are playing catch up now to invest in basic infrastructure and health departments that has been needed to be done for a very long time. So holding on to these positions that get funded and created will be a goal post-COVID. There is enough work to be done. We have out of control other epidemics, STDs, HIV, and other infectious disease outbreaks that come our way. So we need to hold on to this workforce as we go forward. I think obviously there'll be some adjustments to the system once COVID passes, probably to the entry-level contact tracer. But the more advanced disease intervention specialists, there is just no doubt that we need many, many more positions in this country to continue on post-COVID. I think the proposal we advanced with the national public health community to Congress is that, pre-COVID, there was only about 2,000 DIS in the United States, mostly supported, not exclusively. So, the system varies a little bit as you move into states and across the country. But a big core element of disease intervention specialists are supported through the tiny little STD program at CDC. It's terribly ironic. This core public health workforce is funded through one of the more poorly funded programs at CDC. And so we need to ramp that up. We need the other divisions of CDC to also support this function. And some of that is done through the other divisions. But we need to go from the pre-COVID era of approximately 2,000 DIS. You can throw in some federal positions on top of that as well that have been delegated to the states. But we need to get to at least the 10,000 mark throughout the United States. And Mike may want to add to that.
No, I would agree, David. That's absolutely true. I guess my point would be as well that, contact tracing can be applied in lots of settings. There's been some conversation about the potential for redeploying folks that are part of the COVID response into other parts of public health agencies in the future. We know we have a workforce need in public health agencies on lots of levels, and we know we've got a lot of sick people in this country. So the extent to which we have expanded the workforce to deal with COVID, as you mentioned, David, is also going to help us with STI and HIV, communicable disease control in the future, but also potentially redeploying folks to help manage chronic disease, to reach out to communities where there's an urgent need for health promotion messaging and other ways to engage. And so this notion that we're going to hire 100,000 people and then let them go in 12 months, I just don't think we're not talking about that. We're talking about sustained investment in the public health system to deal with COVID for the foreseeable future. And again, until we have a vaccine, we're going to need contact tracing and beyond. And so for me, I think that's what makes this even more important.
And I just want to add too that, the term contact tracing can sound a little clinical and academic. I think one of the beauties of today's briefing is that we put a human face on this. As you can see, those of you who are watching this briefing, people who do this work come from the communities they serve. And folks have, folks who do this work are folks who have a lot of love and a lot of goodwill and a lot of caring that they provide on a daily basis for the health of local communities. And this is not just a quote unquote contact tracer position. These are folks who are navigating people through the healthcare system, getting resources, educating people, doing crisis counseling. I mean, I like to talk about as embodied by you, Guadalupe, Toby, and Danny. You are the people who provide heroic service to people that draws upon kind of a multidisciplinary approach that reaches people in need. And that's really at the end of the day, that's what this is all about. And this is what people who are experiencing COVID need. They need to be supported and heard and helped to deal with this very, very serious infectious disease.
Great, thank you. This I'm going to throw to Guadalupe because I think she addressed this in some of her comments. But there's a question of how effective contact tracing has been over the phone versus doing field investigation and follow-up.
So, I mean, like I said, the modifications are in place, and it has eliminated that face-to-face contact. However, because this is what we've been doing, we're able to address their concerns over the phone. And a lot of times it's just really sitting down and listening to what they have to say. We have to realize that these individuals are isolated at home, right? Their spouse, children are probably out in another room. And so when you get on the phone with them, they're just talking and talking. So it's listening to them and addressing those concerns, and then being able to obtain the information that you need and giving them the information that they need and the support that they need. So it's a two-way, like they benefit from it, and of course we benefit from it as well.
Great. And Toby, did you want to add anything to what Guadalupe?
No, she answered it perfectly well. She said everything I would have said. So thank you.
Great. Sounds good. Okay, and then back to Mike and David. We talked about the funding that's needed today, as well as what would happen in the future for these positions. There's a question of when we talk about this funding, how long are we expecting we need this funding for, in terms of what future fiscal years do we expect we need this amount of funding for?
Oh, Mike, you tackle that one.
Well, I think the estimates that we put together were for 12 months, for a year. I think that really we need, we're moving into 21 right now in terms of federal fiscal year, and we should plan for at least through FY23, at least 2 years. I mean, I think that we're going to see some ebb and flows and hotspots and new outbreaks, and we're just not sure what's going to happen with this virus. And why would we wait when we have the chance now? What did we learn over the last 10 weeks in terms of preparedness? If we have too many DIS, there's plenty of sick people. So let's bring them to the agencies and get moving on this and keep that sustained investment until we know this thing is burnt out. And that's going to take some time. And a vaccine is not going to be delivered overnight. And it's certainly not going to be available to everybody for lots of reasons, not the least of which is folks may not be able to take a vaccine if they have underlying conditions or they refuse it. So we're going to have issues. And they keep coming back. Measles is a good example of that. Thought we were done with that. No way. So we're talking about sustained investment. And I would say at this rate, with this kind of influx of new workforce for contact tracing and DIS in particular, I would say at least a 2-year commitment.
Great. And then we have time for a couple more questions. I encourage those who still have questions to put them in the question and answer at the bottom of the screen, or again, raise their hand if they want to ask it out loud. I have a question here that maybe I'll ask again to Danny, Guadalupe, and Toby. When we're talking about this program and providing contact tracing, how would a system such as this work for areas that have no epidemiologists or DIS workers?
That is a pretty tough question. And I think with different states and coordinating with the locals, I think it really all depends on how we're able to roll out contact tracing in the state. With areas, because for example, in Illinois, not every county has a local health department. So how do we work with that and coordinate with that? And I think it's going to be trying to find the communities out there that actually service the individuals and trying to see if we can coordinate accordingly.
Great.
I want to add, to what Danny said. I don't think this is possible, but there have been times when I have assisted other local health departments that don't have a number of DIS. For example, Evanston Health Department, there was an employee who struggled with working on all of the different programs that she had to do. So I would offer to go with her to help with some training and also help her understand how to do the DIS work. So maybe if people, and again, this might not be possible at all, but if there are people from health departments that could come and at least help temporarily until other DIS and tracers are hired.
And that's a good point. We do have, like, for example, our staff here in the team who do assist with locals in a lot of the technical assistance and questions and answers, and maybe even like the mock interviews, and really practice. But it also, the other thing that we can think about that with contact tracing and technology, it is a possibility to do potentially virtual. So if we can't physically have an individual at the location, maybe that's the opportunity for technology or virtual type of contact tracing.
Thank you all. And there is one hand, I think this will be our last question. I'm going to allow you to talk. Reynaldo Grant, you should be able to unmute yourself now. Reynaldo? If you are there, you are unmuted and free to talk. All right, I think maybe Reynaldo put his hand up by accident. That is all that we have for questions right now. So I'm going to turn it back over to David and Michael to close us out.
Thank you all once again. Congressional staff, thank you for joining us today. We know you are facing very big decisions and some long days ahead as you think about how to take additional congressional action that supports these activities to help the American economy reopen. Please know that I think any one of us on this call today can be a resource to you. Please reach out. We're happy to help. These are unprecedented times, and we very much appreciate you joining us to learn about this core public health function. Mike Fraser.
Thanks, David. And again, thanks to all of our health department folks and our NCSD partners. You guys are doing amazing work, and I'm so impressed, reminded of why I get excited about public health. I hope the folks on the line have the chance to do that too. And we hope that there'll be a vehicle to move some of these proposals forward as soon as possible. So thanks to NCSD for helping organize this, and to all of you for participating.
Thank you. Have a good rest of the day, everybody.